Let me start from the fact that, as you will be aware, I worked in the NHS for a number of years and ran the NHS for 6 years, and am now in recovery, as my friends say. At that point, the Prime Minister, Tony Blair, asked me if I'd go and look at what we could do in developing countries with UK experience and expertise in health to help support health improvement. And I came back and I wrote him a report, and there were a couple of key issues that came out. First one is just stop telling people what to do and start helping them to do stuff that they already know they want to do. Amazingly, one still has to keep saying that because in practice that's what happens. The second one is what a lot we have to offer, particularly in the field of training and education. One of the stories that I will keep coming back to is, of course, we have had a lot of people migrate from low and middle income countries to the UK to the NHS's great benefit. But actually, we have a terrific education system, which if we could use more effectively, we could support health and improving health globally. But the third thing that I really discovered was how much we've got to learn. It wasn't quite what I was expecting, but everyone I met from Brits who were working abroad came back and told me about things that they had learnt from working abroad, not just that they'd learned, but ideas that we could actually adapt and bring back into the UK. So let me give a very brief advert. I actually wrote a book about it called Turning the World Upside Down, and if people do want copies, I can sell you some at the end. But that's the brief advert. What I want to do is to talk about this thesis of turning the world upside down as perhaps one of the core issues that you might want to use in terms of your future work. So let's start with the global context. And there are a number of really key issues here. And the first one, which really wasn't relevant 15 years ago, if you'd been running the NHS in the 1990s, you'd be thinking about the NHS in England and working within those parameters. If you're doing so in the 21st century, you've got to think about interdependence. Interdependence in all kinds of ways. The most obvious, of course, being the way in which diseases can spread around the world. The fact that a microbe can get on a plane and travel at the same speed as any of the rest of us. The fact that in the 14th century it took 3 years for the Black Death to get across Europe, and at the beginning of this century it took 3 days for SARS to get around the world. We know that we are vulnerable. We know that we are vulnerable to the weakest areas of the world. There is a matter of self-interest here in our interest in actually strengthening health systems in other countries where some of these diseases may arise and incubate and start to spread. But we're interdependent in other ways. I mean, another obvious one is climate change and the impact on that, or indeed that a power station blowing up in Russia may affect health in Wales, or in fact that we're so interdependent in terms of the staff we use. Health staff, I think, are probably the most mobile people in the world. They can travel around and get jobs wherever they want. There is increasingly a global market, if you like. We're interdependent in using the same drugs. We're also interdependent, it seems to me, increasingly in using the same knowledge base, and that is, of course, wonderful in some ways, but there is a sense in which our models of Western scientific medicine have also rolled over some of the more local traditions and some of the more local knowledge as well. So interdependence is absolutely core to thinking about global health in the future. There's also something which I call the unfair health trade, and forgive me any economists in the room, trade is not a proper description, it's a metaphor. And what I'm talking about here is that we in rich countries tend to import health workers from poorer countries, and in exchange we export our ideas and ideologies, whether they work or not. And you see this very clearly working in Africa, about the British health workers who will be thinking in terms of the NHS and British sort of models of doing things and looking through their NHS spectacles, if you like. And then you'll meet the American health workers, and they, of course, will have different models in their mind, different models more based on insurance, for example. And what I'm arguing in my book is what would it be like if we turned it the other way around? If instead of that, we actually exported some of our health workers, particularly for training and education, and we imported some of the ideas and the innovations that are happening around the world. And that all takes place in a context of power. As Albert has very clearly said, we know that there is a power imbalance here, and it manifests itself, for example, in the terms of trade, in the way that sub-Saharan Africa gets about 3% of world trade and about 2% of foreign direct investment. We know that there is that at almost every level internationally, the high-income countries hold the whip hand and hold the power. But we also know that's shifting, and that people are starting to assert themselves from different areas of the world. And I take the simple example of Indonesia a few years ago, where the Indonesian government refused to release tissue from people who died from one of the epidemic flus. They'd refused to release tissue to the rest of the world because they said, you will take it and you will develop vaccines and treatments that will only be available to people in rich countries. Now that was really quite a standoff between a country and the rest of the world, and asserting their position, and that it was only appropriate that if you were using tissue from our people, that our people should benefit as well. And you're starting to see that happening in that assertiveness, but also you're starting to see it happening in countries like India, where in a sense they're just moving on. They're not even being assertive, they're just moving on and developing some new ideas, some of which I'll touch on. There's another area which I'm not really going to speak about, which is the right to health, enshrined in 1948, 1946, I can't remember, but of that order, and gradually increasing these statements of rights. I expect some future speaker will be talking about this over the last 60, 70 years, culminating 3 years ago in the African Union being very explicit about the right to health for people in Africa. So how does that play into our conversation? But the issue that I want to talk about as much as anything else is this last one. It's co-development. We have tended in recent years to think about international development as a way of sort of top-down Western experts telling other people what to do, whereas I think the future for us in health, and indeed in development, is co-development. So in that notion that the globe and global health is about all of us, and that actually you should try and get as far away as we can from talking about developing countries and developed countries, let's actually start in the rich countries and just consider where we are today. Well, in the rich countries, we've had a fantastic success in the last century. Through greater professionalism from Flexner onwards in the last century, great scientific discovery, great commercial development, increasing funding, and at the same time, we've seen great changes in society. This is a map which starts in 1900 at the bottom and goes to 2000 at the top, and the indication of these three columns is the way in which we have had things happening over the last 100 years that have improved our health, whether it is the greying of the professions and new anaesthetics in the early part of the 20th century, or whether it is greater education and health and safety at work in the second half of the 20th century in my society column. All of that has been a fantastic success. And if you're a British man in 1900, your life expectancy was 49. If you're a British man in 2000, your life expectancy was 79. That's 30 years in a century improvement, or 3 years a decade. Or if you prefer to look at it another way, it's almost 8 hours a day. Now, depending on how your day's been, you may or not value that extra 8 hours that you just gained by living this long. Great story. But the trouble is, life has changed. Life has changed in 4 big ways and is continuing to change. Firstly, the diseases and conditions that we suffer from are different. People will be very familiar with the story, and you only need to read the British press now to know that we've got an NHS that is focused on hospitals and medical procedures, and we need an NHS that is much more focused on how do you look after long-term conditions, people with recurring problems, increasing numbers of older people who need to be based much more in the community. The conditions we try and deal with are changing. Patients and the public are changing. Their behaviour is seen as more important. They're part of the solution and part of the problem. Science and technology is changing, and as I've said, health is becoming more global. So we now see that the model we've got in the UK is part of the problem. And this is the link that I want to make to low and middle income countries, is where are we going to get the new ideas? Who are doing things that we can learn from? And there's a whole range of people. There are pioneers, of course, in our own country. We can learn something from other industries and other areas. I think we can learn a lot from young people and their expectations and their ways of behaving. We can learn a lot from disabilities and rights groups who over the last 30, 40, 50 years have been asserting themselves and creating new ways of thinking. But we can also learn a great deal from low and middle income countries. So let me, just before doing that, let me just be clear that when we're talking about low and middle income countries, this isn't some kind of romantic notion about what could happen, and that people in low and middle income countries have much worse problems than we have here in North London. Poverty, social issues, internal and external power relationships all damage and affect health. And if I just take one of those power relationships, There are many women in parts of Africa don't get access to healthcare for a whole range of reasons. Many of them are societal rather than just to do with resources or money. And there are enormous shortages of resources and health workers. One of the series of figures that I always bear in mind is that sub-Saharan Africa is 10% of the world's population. It has 25% of the world's burden of disease. It has 3% of the resources for healthcare, and it's got 1% of the health workers. Now, if you translate that into the big hospital that's just next door to us, you'd be dealing at UCL with the same burden of disease with, instead of about 600 doctors, you'd have about 12 doctors. This is a massive difference in terms of what people are actually trying to do in these countries. And one of those shortages is of health workers, and let me just deal with an issue that may come across as one of the things you want to pick up on, which is health migration. Really important issue, but if you look at the figures, you'll discover that over the last 35 years, about 135,000 people have migrated, health workers have migrated from sub-Saharan Africa to richer countries. Very big number. But the shortage in sub-Saharan Africa is about 1.5 million. So actually migration is a part of the problem, an important part of the problem, but the biggest single issue, and this is again where the UK can contribute, is in education and training. Not enough people are being trained. Ethiopia, until recently, a country bigger than ours, was training only just 100 doctors a year. We train almost 8,000, and as I say, we're smaller than Ethiopia. So huge shortages of resources and health workers, and as has already been said by Albert, non-communicable as well as communicable diseases. And let me just give you two maps that show a brief tale of two epidemics. Clearly there are some things that affect some parts of the world more than others. I guess people have seen these maps before where the countries are shown in proportion to the size of the problem. So this is the number, this is the distribution of HIV/AIDS around the world, and we can see where the epidemic is centred. But then you look at this one, and this is non-communicable diseases. And again, you can see actually that even Africa is not as thin as you might have expected, and is now suffering from that. And you can see that bloated pink thing in the middle, which is an indication of how much the UK has got of an obesity problem, reflected rather well in this map in terms of non-communicable diseases. But this is the epidemic that we all share, and this map shows it very clearly. So what innovation is coming from low and middle income countries? There are some very obvious things and some specific things around HIV and AIDS, and such as the treatment of HIV and AIDS has been learned in Africa. There are specific conditions where people have developed ways of dealing with things like club foot, for example, that have now been imported or re-imported into the rich countries. Policy initiatives like conditional cash transfers developed in Mexico, which were then developed in Mexico in the 1990s, then introduced into New York in 2007, with Mayor Bloomberg explicitly saying he was copying what they were doing in Mexico. Some very fascinating product development around things like eyes and cataracts. Aravind in India, a really exciting organisation, which was faced with the problem of trying to provide eye care for a poor population with a great need, and developed different ways of doing it, even developing a different lens for cataracts, which was much cheaper than the ones that were available from the West. A very good example there of people without our resources and actually without our baggage innovating in ways that we haven't done. Telemedicine obviously developing in a number of places, and identified by big institutions, the commercial institutions like GE Healthcare, I know represented in the room, and McKinsey's. And I pinched this from McKinsey's, the management consultants. This is their map, which they presented at the World Economic Forum last year, of where they think the most innovation in healthcare delivery is happening around the world. Now, you can't read it, but the really important thing is to see the spread. Awful lot happening in India, as you'd expect. Quite a lot more than you might have thought happening in Africa, South America and so on. The only bit of Europe that gets represented on this map is Spain. Now, you can argue about whether these are actually the 25 most interesting innovations around the world. And you may also wonder how many of them are McKinsey's clients, but that's only if you're truly cynical. But the point is made, whatever map you make, you're going to end up with a map that looks a bit like this. Innovation is happening around the world. And the old patronising attitudes of that knowledge transfer is one way need to disappear and need to be not part of our continuing discussion. But more interestingly than those individual elements of innovation is there are new traditions developing. There's emerging traditions of people making much more use of community and family and women and linking health, education and work together. I take the example of BRAC in Bangladesh, really interesting voluntary group, very large voluntary group, I think the biggest NGO in the world, where they not only work with women, for example, with their sick children, but also support them with education and provide them with opportunities through microfinance to actually get into employment or to create their own businesses, recognising, of course, that health is not an isolated issue and that health, education and work link together. More social enterprises, much more linking of public health and clinical medicine. And you'll see from the sort of picture I'm painting there how much this is relevant to our condition in this country, where we're thinking about how do you manage long-term conditions, and you need to do them with people from the community in different ways, linking in with education, linking in with employment and everything else. And the fifth item on this slide is the really challenging one, which is, of course, that in many countries people are training people for the job and not just for the profession. And what I mean by that is cataract surgeons. What I mean by that is Mozambique, where in Mozambique, for example, outside the capital, essentially all the cesareans or C-sections are done by nurses with a bit of additional training. And these have been researched for about 15 years by European groups and published in respectable journals like the British Journal of Obs and Gynae, and have demonstrated that the results are as good as if the cesareans were done by doctors, the same level of complications, that they're half the cost. And of course, in that context, that the nurses stay in the country, whereas the doctors will migrate typically to South Africa or indeed to Brazil. So I'm not suggesting that we do all our C-sections with nurses or all our cataract surgery with cataract surgeons, but these are real challenges to what we do. And I observe lots of British health workers working abroad who come back realising that there are different options and challenging their own boundaries. So what are the implications of all this? I'm actually arguing that we shouldn't be thinking about health in poor and high-income countries in different ways. There's a continuum here. We need to frame our response in a number of different ways. One of them is there was one other item that I think comes out of this emerging tradition, which is that people are actually focusing on something slightly different from not just trying to create and improve health. They're actually thinking about helping people to be more independent, seeing the world in terms of people's lives and not just the services we can offer. And that's very true in this country as well, that when people get ill, very often what they're looking for is to get their life back. I remember my 90-year-old father broke his arm. He had his arm in a sling for 6 weeks and a bit of physio, clinically, dead simple. The real issue was, could he continue to be independent? Could he continue to live by himself? That was the goal. And you see a lot of these countries focusing very much on that sort of goal of helping people to live a life that they have reason to value. So in this context, I think we need to frame our response in a number of ways. We need to think about co-development. And there are benefits of co-development for poorer countries. What happens then is country-led and owned, it's culturally sensitive and respectful, and it's able to draw on all traditions. And it can avoid some of the faults and weaknesses that we impose in our views of the world, and it recognises the shifting balance of power. But equally, there are huge benefits for us. I see British NHS workers who go abroad even for 2 weeks and come back remembering why they were a doctor. It's about refreshment and personal development. It's about greater cultural awareness. If you happen to work in the East End of London, it's very useful to know something about Bengali culture. It's about learning some specific skills and practices, but it's also about challenging our long-held ideas and about shaping the future together. I think there's also some implications in what I've been saying for science, because if science is going to be working in this context, I think there are three key messages here. The first one is how much can we ensure that the research is spent on early health and creating things that are helping people to look after themselves rather than on late disease. It's actually the former chief executive of, in fact, the current chair of the Wellcome Trust, Bill Castell, who actually coined this phrase that we should be looking at early health rather than late disease. We should be paying much more attention to diagnostics if we're going to have an impact around the world rather than expensive late treatments of disease. Is science going to be working on things that are available to all or only to the few? And importantly, is science going to be, and the products of science, going to be promoting independence, or is it going to promote even greater dependence on the professionals and the health workers, as some recent developments have done? Now, I approach all of this as a practitioner, and I see this change that I'm talking about happening around the world. I see the world getting much more joined up and people learning from each other. And I think we need to accelerate this change, partly by making it visible and coherent, and that's partly why I've been writing about it. A very big part about it is how we change health worker training and education. I hope this might be an issue that you will pick up as part of your thinking for the future, is if you're thinking about a different world, what are the things that your health workers need to be educated and trained and learned and socialised around? But it's also about experience and exchange, because almost everything I'm talking about has come from individuals from the UK meeting and mixing with people from elsewhere, and vice versa. And I think that's enormously valuable at every level. And I offer as finally, as a final framework, that what everyone's doing in thinking about the ethical framework for the future for health and dealing with these inequalities, I think there are three sets of issues that need to be brought into that in some way. One is about this issue of interdependence. It's not us and them, actually we're in this together. But it's also the issue of independence, and that what people are looking for from health is the ability to get on with their lives and not a dependence, if you like, on the medical professions and the health professions. But into that as well, we need to play this notion of rights and what people's rights for health really mean. It's not the right to choose the gynecologist that you want. It's the right to expect that whatever country you're living in, that your country and your government does something about ensuring that there is healthcare available to you as an individual. So finally, my very final point is that this is a global issue and we need to treat it as a global issue. We're in this together and we can all contribute. And a phrase that I think sums this up very well is that looking at the future, each of us has got something to teach and each of us has got something to learn. Thank you very much.